Assalamu alaikum wa rahmatullahi wa barakatuh. Now, this is the third part of our discussion regarding this anti-epileptics. After discussion about the phenytoin, the carbamazepine, now we are going to see about the phenobarbital, or the other name of this drug is Phenobarbitone. Although it's one of the safest anti-seizure, but it have very pronounced sedative effects. Important barbiturates include phenobarbital, methylbarbital, methobarbital, primidone, which are used as anti-seizure agents. All are the derivative of barbituric acid. They are also considered as a drug of choice for seizures only in infants, especially febrile seizures, febrile fits. As far as the mechanism of action is concerned, we have already seen in the set of hypnotics Phenobarbital at all, it inhibits the seizure by potentiation of synaptic inhibition through an action on the GABA A receptor. At the therapeutic concentration, it enhances the GABA A receptor mediated current by increasing the duration of colloid influx, while in case of benzodiazepine, they were increasing the frequency of colloid influx opening. That is the only difference. Both were enhancing the GABA A receptor mediated current, but this phenobarbital increases the duration of colloid influx. It also reduces glutamate mediated excitation. So result is both producing inhibitory effect in the brain and anti-epileptic effect. Toxicity of phenobarbital. Obviously, the most pronounced effect is the sedation. Number one and number two, at the same time, development of tallness, especially when phenobarbital is used for prolonged period. So these two adverse effects usually limit the use of phenobarbital as a commonly used anti-epileptic drug. Other effects includes nystagmus and ataxia, but these effects are usually seen when the dose is increased. Sometimes these barbiturates can produce opposite effect like irritability and hyperactivity, especially in children, and even agitation, and in elderly confusion is seen. Drug allergy in the form of scarlatiform and barbiliform rash have been observed up to 2% of the patient. However, this severe type of exfoliative dermatitis is very rare. But hypoproteinemia with hemorrhage have been observed, especially in the newborns of those mothers who have been taking phenobarbital during pregnancy due to any reason. It may also cause megaloblastic anemia, but usually the megaloblastic anemia produced by phenobarbital that responds to folate and osteomalacia produced by it can respond to vitamin D, while in case of this phenytoin, osteomalacia produced by phenytoin cannot be treated with the supplementation of the vitamin D, but this can be treated with the vitamin D. As far as the uses are concerned, especially useful in the treatment of partial seizures, generalized tonic-clonic seizure, infantile seizures, and virtually every non-responding type of seizure. However, as far as the absences or atonic attacks are concerned, it's very, very little effective. Next important drug is Primidone. Now, the other name of Primidone is deoxyphenobarbital. So that means basically it resembles to barbiturates, and when it is metabolized, it is metabolized into phenobarbital mainly, but at the same time another active metabolite, PEMA, phenylethylmelanoamide. Usually all three compounds, Primidone, Phenobarbital and PEMA, all are active anticonvulsants. The mechanism of action of Primidone, however, is not resembling to barbiturates Primidone itself, but is more likely to phenytoin, sodium channel blocking effect. Primidone and its active metabolite PEMA both are active against partial seizure and generalized tonic-clonic seizures. And usually Primidone is more effective than the phenobarbital itself. For complex partial seizure, usually we prefer carbamazepine and phenytoin because they are superior to Primidone. If it is used in newborn, it's very slowly metabolized, so it stays inside the body of the newborns. Also, this Primidone is effective in controlling seizures in the newborns and in older patients. So, its slow metabolizing capability should be kept in mind. Next group is benzodiazepines. We have already studied this group under the heading of sedative hypnotics, and we know benzodiazepines, they modulate the GABA A receptor. But here, as anti-epileptic, we see there are so many benzodiazepines which are useful as first-line drugs in the acute treatment of different types of seizure, especially in status epilepticus or even acute repetitive seizures, also known as seizure cluster, because here the seizures are coming repeatedly in the form of cluster. But their usefulness in this chronic epileptic attacks, benzodiazepines have very limited role because they produce very pronounced sedation and also the tolerance. So due to that reason, we restrict the use of benzodiazepine only for the acute treatment of the acute states. Diazepam. This is one of the important member of this group of benzodiazepine. So as we have seen, because this group is used for acute states, so it is given intravenously as a first line treatment for status epilepticus. But it can be used as a rectal gel in the treatment of acute repetitive seizure, what we call a seizure cluster. So benzodiazepine is used only for these two acute states. Its other member is the lorazepam. That is also given intravenously for status epilepticus. But it has more prolonged duration of action. Midazolam, it can be given intramuscular, and it is a preferred treatment for the status epilepticus if there is some delay to the hospital for intravenous use of these benzodiazepine and lorazepam. For that particular time, we can give intramuscular injection of midazolam. Now, clonazepam, another very important member, but it's a long acting and it's one of the most potent anti-seizure agent. Its dose is very, very small. It's very good in the treatment of absences, atonic and myoclonic seizure. But obviously sedation is the most prominent aspect of clonazepam also, especially when the therapy is started. So usually we start even smaller doses of clonazepam to avoid the sedation or to minimize the sedation. Next drug is nitrazepam, and specifically it is especially useful for the infantile spasm and the myoclonic seizure, while the clonazepam for the focal seizure, but obviously it can produce drowsiness and lethargy, which is very common advices. So again the dose is increased gradually. Initially we start with the lower dosages. And lastly, clobazam. Now, its usefulness is only in the atonic seizure currently. After this group, the next drug is the ethosuximide. Ethosuximide is the first line drug for the treatment of generalized absence seizures, and it can be used as a monotherapy also without adding any other drug. But if there is generalized tonic-clonic seizure, usually we add, or we can use valproate alone, because valproate is preferred for the generalized tonic-clonic seizure. Or some other effective drug can also be combined with the ethosuximide. As far as the mechanism of action is concerned, it acts by inhibition of calcium channels in the thalamocortical neurons. It may also act on the sodium channel or potassium channel, especially calcium activated potassium channel. So due to these three, but the most important is the T-type calcium channel inhibition. It can show its anti-epileptic effect. As far as the uses of ethosuximides are concerned, especially in childhood, generalized absence seizure, or even atypical absences. It is also useful in myoclonic, especially epileptic negative myoclonics. For better anti-epileptic effect, as we have seen, we can add valproate or even benzodiazepine with the ethosuximide. Adverse effects are usually dose related. With smaller doses, these are less, but they go on increasing if we increase the dose. And the most common are gastric distress with the abdominal pain. Ethosuximide can also produce nausea or vomiting. There may be transient lethargy and fatigue also. So to avoid this, reduce the dose. Less common adverse effects include headache, dizziness, hiccup, or even euphoria have been observed with the ethosuximide. Behavior effects on the patient, usually those are improved with the use of ethosuximide. Idiosyncratic effects have also been observed, but these are very, very rare. Valproate. Again, this is the first line broad spectrum anti-seizure drug. Mechanism of action of valproate is similar to that of phenytoin and carbamazepine, especially by prolonging the inactivated state of sodium channel. It also reduces the activity of calcium channel, especially T-type calcium current, which is similar to ethosuximide we have just seen. It increases the GABA levels, but that can't be related to its anti-seizure activity. So as far as the anti-seizure activity is concerned, valproate can show its activity only either through inactivation of sodium channel or the calcium channel. There are a variety of uses of valproate: juvenile myoclonic epilepsy, atonic seizure, generalized absential seizures, and if these generalized abscesses are occurring with generalized tonic-clonic seizure, usually ethosuximide is used instead of valproate. For the focal seizures also, but here carbamazepine or phenytoins are preferred. Or we can use this valproate for the status epilepticus, but then route of administration intravenously. It can also be used as a mood stabilizer in the bipolar disorder. And even for migraine, prophylactically, it is quite useful. Toxicity of valproate, obviously most common are the nausea, vomiting, abdominal pain, and heartburn. But remember, these are dose related again. At the higher level of the dosages, fine tremors can be observed. We have also seen weight gain, increased appetite, and hair loss in the patients using Valproate. As far as the idiosyncratic reactions are concerned, fatal hepatic toxicity is very rare, and if seen, it is seen especially in the children under 2 years of age. Thrombocytopenia is also observed, but bleeding with this thrombocytopenia is also very rare and less. It can interfere with the conversion of ammonia to urea. So that is why there is increased ammonia concentration with the use of valproate. That increased ammonia concentration can produce lethargy in the patient, or even there may be fatal encephalopathy. The first trimester of pregnancy, this valproate is associated with the risk of spina bifida, neural tube defects, up to 2% of the patient. There may also be cardiovascular or orofacial or digital abnormalities in such patients. If the person has been using throughout the pregnancy, cognitive impairment may be observed in offspring of that patient. Next drug is levetiracetam. Now, levetiracetam is a paracetam analog. Remember, it is a broad spectrum anti-seizure drug. Broad spectrum. It is one of the most commonly prescribed drugs as far as the anti-epileptic therapy is concerned. And the main reason for its commonly prescribed drug is because it produces less severe adverse effects. It has broad therapeutic window, very safe also. Its pharmacokinetic properties are very favorable to be used. And as far as the drug interaction is concerned, it has almost no drug interaction. So that is why it is one of the most commonly prescribed drug, levetiracetam. As far as the mechanism of action is concerned, levetiracetam binds selectively to the synaptic vesicle protein present in the nerve ending of the glutamate neuron. So thus, after binding it, it reduces the release of this glutamate, which is actually an excitatory neurotransmitter. So in this way, it is producing inhibitory effect. Its pharmacokinetics, as we have seen, when given orally, it's very rapidly and completely absorbed, and its peak plasma levels are achieved within an hour or so. However, it should be taken empty stomach because food can slow the rate of absorption. Mainly, it is present in the free form. Even less than 10% is present in the plasma protein bound form. Its half-life is up to 8 hours, but this half-life has been observed as increase in elderly patients. It is mainly metabolized in the blood, no hepatic metabolism. So, as said previously, drug interactions are almost none. As far as the clinical uses are concerned, mainly for the adjunctive treatment of partial seizure in adults and children with the other anti-epileptic agents. Also useful for the primary generalized tonic-clonic seizure and juvenile myoclonic epilepsy. Adverse effects we have already seen: very minimal drowsiness, muscular weakness, ataxia, dizziness, etc. at the most. As far as more serious are concerned, those adverse effects are very less common. Changes in the behavior and the mood like irritability, aggressiveness, agitation, anger, anxiety, apathy, etc., depression, and even emotional lability. These are very rare. So, thank you very much for this third part of antiepileptics, and after some time, now we will again see with the fourth and the last part of antiepileptics. Thank you very much.